Good morning. This is Sarah with the Department of Medicaid. It's not quite 11 o'clock and we're still clearing the waiting room, so we'll give it just a moment before we get started. Good morning. It is 11 o'clock, but we are still clearing the waiting room, so we'll give it just one more minute before we get started. Okay, good morning. Our waiting room has now cleared. So I have Susan, Evan, and Lynn, Titus, and Meryl. I think I have all of you today. So I will turn it over to you.
Good morning. Can you hear me?
Yep.
Oh, good.
Yes, ma'am.
All right. I wanted to thank everybody for being here. And we'll get started with the introduction of the TAC members. I'm Anlin Purdon with Hazelwood Home Health.
Susan Stewart, Appalachian Regional Healthcare.
Good morning, Janet Marlene Reynolds, LHC Group.
Good morning, Elvis Perez, with the Health Department. Good morning, everyone. I'm Evan Reinhardt with the Kentucky Home Care Association.
And we've already established we're all here, so we have a quorum. First order of business is to approve the minutes. I believe it'd be the February 13th, right? That was our last meeting.
Susan Stewart, I'll make a motion to approve those minutes.
Second.
I will second.
All in favor?
Aye.
Aye.
Leave. Is that everybody? Okay. All right. So old business, Evan, if you want to go over that, and then I believe the new business is all mine, and I'll do those.
Sure, sounds good.
Thank
So
you.
just returning to our supplies limits discussion, You know, that obviously continues to be an issue for us, and we had done some separate investigation on our end. And I don't believe, you know, for our purposes, that home health supplies that we're discussing have ever been on the list that where CMS, you know, deems them confidential. So, you know, we're just returning to that and trying to understand, you know, if there's a way we can get those limits, you know, to better expedite the billing and reimbursement process, and, you know, where DMS stands on that and where we're going to go from here. So, Aaron, I don't know if anybody from the DMS side is here to be able to chat about that, but you know, that's something that we're definitely interested in still pursuing.
I am scrolling through the list. Let's see here. I'm trying to see if anyone from the MCO contracting group is on, but I'm not seeing anyone. Can anybody, April, I see you're on. I don't know if that's really your area.
So, also we have with us today Carmen Hancock, our Division Director for Long-Term Services and Supports. But we have also completed analysis and review of those supply limits and also made recommendations. And those are with the Commissioner's Office and reviewing. And we hope by next meeting that we will be able to provide a better update on those. We had reviewed the CMS as well as we reviewed other states' supply limits, et cetera, fee schedules, and all that has been sent over to the Commissioner's Office for review.
Do you have any sense, April, of an ETA on that?
I know we have a meeting scheduled next week to discuss further, and as we have updates, we are more than happy to pass those along through Aaron to you, Evan, to push those out.
Okay. And I mean, is it safe to say there's a sort of policy consideration on happening on your end, or is that anything you can speak to at this point?
We will be able to provide better updates once we know when the Commissioner's Office reviewed. They have not only just reviewed like the home health, they're in the process of reviewing all the fee schedules for 2025.
Okay.
April, do you know if that will address this issue that we've been dealing with for a few years now?
Yes, I know that was one of the items that we worked on reviewing and making recommendations for. Again, it's ensuring that everyone has reviewed and agreed to follow through on that. So just ensuring that everybody has eyes on it, from Commissioner's Office to finance team.
Well, I just want to make sure it's not just the annual review of supply limits, that our point is part of that review as well.
Yes, and that was considered and that information was provided. I know the HEB team, Laura, where the home health falls under, they had taken all of that into consideration and review and provided all that information as a policy recommendation.
Okay, thank you.
Thanks, April. If there's anything we can do to help, you know, or any feedback you need from our end, please just let us know.
Will do.
All right. Any other discussion or anything, Anlin or Susan, on supplies limits? Okay. Home health aid utilization. So pre and post MCO numbers, you know, we've actually received the data at this point. You know, a little bit shocking to say the least in terms of the utilization trend and decrease overall. You know, so what we're seeing from the data is that we've gone from, I think it was around 2005 at a height of over 100,000 units to, the last couple of years, kind of 3,000 or 4,000 units total per year in terms of utilization. So very concerning to us, as an industry. That's even within the lowest cost, part of the healthcare landscape. That is, one of the more cost-effective ways to deliver care and have frontline opportunities to touch, patients and observe their condition. So to see that just drastic downward trend of utilization, very concerning to us. Interested in any feedback any of the MCEs might have, as well as DMS, to better understand how and we might be able to change that trend and start going back in the other direction. But to that point, I think our discussions have been, particularly on the managed care side, there just aren't authorizations for home health aides. That doesn't come through as a part of the prior authorization process. And it's somewhat of a head scratcher for us as within the industry, because again, that is the best way and most cost-effective way to have folks out there, laying eyes and sometimes, hands on the patient to see where they are in terms of their, disease process, or just overall condition, or even the behavioral health side. So, all of those things are concerning to see that significant of a shift. So, open the floor to obviously the MCOs or DMS on this, but this is a high priority for us, because that data is really shocking, to say the least. I don't know if Aaron, if anybody from DMS is able to talk through the DMS side of that, but we certainly would love to continue this conversation. It'll be something that's on the TAC agenda going forward as a recurring, similar to our supplies limits conversation.
I can add that to our follow-up and make sure that they have that data to review as well. So if you have any particular questions that you want to send to me, I can send off and have you guys some answers before our next meeting.
I mean, would it help for the next meeting for each of the MCOs to give us their guidelines on what they're looking for before they approve an aid?
We can request that information as well.
Yeah, I think that'd be a helpful start, just to see where the MCOs are, what their policy is, and why that may have played a role in where we've gotten to. So that would be the starting point. And as a part of that, Aaron, we might have some additional detail that we request, but it's again very concerning to us where those numbers are currently.
Hi, Evan. This is Suzanne from United Healthcare. I have a couple of questions, if that's okay.
Sure.
So do you have the data that you can show us or share with us? I think it would be really helpful if you had some information, to give in terms of, over what period of time did we see the drastic reduction? Did this happen gradually? Like, I personally I need a little bit more information on, I think you said it went back to 2005. So we're talking over 20 years. Is that correct?
It's 2006.
Okay. So still, yeah, a really long period of time, but do we have something that shows over time what that looks like, what that trend looks like? And then, because that's a long period of time. And then I guess my other question would be, what, if any, changes DMS may or may not have made in terms of benefit coverage over that time period. And so those are just some questions from me before I go digging on my side. I want to help me understand, because I wasn't, around 20 years ago doing this. So like I just understanding the lay of the land. And there may be other people on here who can speak to that better than I. But I'm just wondering, if you guys can provide us a little bit more information, and then I can go, see again, United hasn't been doing this in Kentucky for 20 years, so I can give you what we have today. But I can't tell you the lay of the land in Kentucky specifically over the last 20 years. So I almost feel like that's more of a DMS, but I don't know. So I just wanted to ask those questions.
Aaron, are we at liberty to share the spreadsheet?
I would assume so, but I will double check just to make sure.
Okay.
I would assume a data request the MCOs can make the same data request, so I would assume that's okay for me to share. I'll just run that up the chain just to make sure I don't get in trouble.
Okay. But to answer your question, Suzanne, I mean, so understand there's context here and it's over 20 years, but in 2022 to show that there are only 3,400 home health aide visits. I mean, just the way our industry is set up, that kind of that's a big head scratcher, because there's definitely more than 3,000, folks receiving the service. And in theory, all of those folks should have some element of home health aide services as a part of what they get authorized. So definitely happy to follow up, but at a height of over 100,000 in 2006, and basically every year, you're losing 2 to 10,000 visits over that time period. So hopefully Aaron can share the data and you guys can get that context. But all that we received was the year and the total claims from 2006 to 2022.
And just to add, there has been no policy changes on home health aid or the regulations of what you need to provide that. Anybody can correct me if I'm wrong, but I don't think there has been over 20 years. Only policy changes. They got MCOs.
You're right, Anlin. There's been no policy change, but basically what we've seen is the complete, almost eradication of an entire service.
And I think the spillover effect, in addition to the services not being authorized, for the folks that have the agencies out there in the field, because they don't have home health aid services being a part of a PA, they can't hire an aide. They can't, they don't have enough work to give that person to go out and provide the service. So that's a direct workforce impact as well. You'd agree with that, Anlin and Susan, that there's just not enough to even really be able to hire somebody?
We don't. Actually, we've had an uptick here recently, but that's just been because our census has went up. Before that, for the past 2 or 3 years, I didn't even really have enough to employ one full-time aide. And I was just lucky that she's willing to take fewer hours. So, the week she had more, that's great. The week she had less. But then you always have to have two because one will be on vacation or sick at some point. So we have to supplement the other one with time in the office. So, yeah.
Same for us.
The same for LHC Group across the state as well.
And this is just, I don't know, my view from my experience. When it was traditional Medicaid, so long as there was a skill in there, then they could have an aide. I think the MCOs, or from what I get from their denials, is they won't approve it at all if they have family members. And then if they do approve it, it's just for a very short amount of time. And in theory, yes, we should be having our OT help them learn how to take care of themselves, but that's not always possible.
Another question. This is Suzanne again. I know that family members, or at least I think family members, could get paid to care for that family member through like different programs. Has that? I mean, I just wondered if maybe that has been part of the uptick in family members engaging more versus, and again, not sure of this, so I'm just asking you guys who have been in this industry for far longer. Do you think that has anything to do with it?
I haven't seen where, I mean, in all the years I've been with home health, there were programs where the family could be paid. And then normally in those, we didn't provide an aid, or we only had an aid as a supplement when the family wasn't there or couldn't be there.
Yeah.
But in most of our cases, they don't have family, or not family that lives around and takes care of them.
Okay.
And the thing about family is they have to be willing and able, and therein lies the problem.
Anything else on that, Suzanne?
I'm probably gonna have more questions, but not right this second.
Sure.
I'm still thinking about it, but thank you.
No, fire away. You've got our contact info, so we're happy to dig in on this. But I think it's something that's been on our radar for a while. Yeah. Just from a workforce perspective and just overall, industry perspective.
Okay.
All right. Unless anybody else has anything on that, we'll jump down to the EBV claims denial issues. Anlin, I think, does that come back to you? I think both you and Susan were chatting about that.
Yes.
I think we both have it.
Yeah, I've not had many denials outright. Right now, I think I'm fighting one. I have a problem where it doesn't ever show up in the aggregator as accepted. And when I contact the insurance, they say that they have accepted it. They've sent that. So I have logged a case and their FSIS are working on it now. Now, the other part about it being an extremely administrative burden, it is. I mean, I know the state's required to do it, but it could be a full-time job.
It is a full-time job plus for ARH. I would like the state to entertain extending their radius a little bit, because maybe that would help reduce the denials, because even if you're in the same driveway, sometimes it'll pick up at the house you're in, and then when you leave, if you're still in the same spot, it'll pick you up at the house next door, and you'll get a mismatch address. So could there be entertainment of extending the radius?
I've taken that down as a follow-up to go back and monitor that as well. That was the first, I did not realize that there was that many. That's not necessarily, we don't consider that a denial. That is an exception, and the provider must clear that exception before. So it's already at a half a mile around the resident's address, unless you all have entered a secondary address where that visit is to take place. So that's anything greater than that half a mile radius would require an exception before that visit would get moved over to the aggregator to work towards, the claim processing. So I have made a note and we will review that. So if you all don't care to send Aaron a follow-up on that, we will go back and discuss that.
I've got it on my follow-up email, April.
Thank you.
I feel like that would could help reduce the administrative burden if we could do that. We in our region we have quite a bit of Medicaid, and it is very labor intensive to do the EVV.
And then as far as the response file, I know that a ticket had been logged with THERAP. We also had conducted some outreach and follow-up as well with Humana. So that was the EVV technical team has done that, and they're working on resolving that issue as well.
Thank you.
And if we, our revenue cycle person just sent me over our denials. I guess we can redact them and send them to you, Evan. Okay.
And this is Herb with Humana. So was that tied to the response file back to THERAP? Is that what you're referring to, April?
Yes, that is correct. That's what I was referring to.
Okay. Yeah, we provided that information back to THERAP, and I think they were researching that.
Yeah, my original one was Humana, and then I had it happen with Aetna, and I had logged a case with their app for that because they actually sent me their response file where they had accepted the visits. So hopefully that'll get corrected.
Yeah, I think we had an LMCO discussion about EVV in general, and I think there was some issues where if the providers weren't using THERAP directly, but using like a third party, then I guess there may have been some kind of a delay in that processing with THERAP from the third party that I think some of us were seeing tied to the aggregator IDs coming in in a timely fashion to hit the claims. So just putting that out there for the group that if you're using a third party EVV that then has to connect to THERAP, you might have some delay issues.
We don't have that issue. I mean, we don't have that scenario.
Okay.
Yeah, we don't either. Hopefully one day. A software will get up and running with their EVV, but not as of yet. All right. Do we have anything else on EVV? Nope. Okay. On to new business. I had sent an example of the A6199 code denying to Evan, and I believe he sent that on to DMS. And I'm having issues that I'm looking at it now. It's on the fee schedule for home health. We get it approved, and then on the claim they denied it, saying it's not a covered supply.
Evan, is that the one you had sent to Kelly?
Yes.
Okay, I will follow up on that one.
I'm hoping it's just a check mark in the system. We've had this before on other supplies, and somehow they get unchecked in the system as being payable. So hopefully it'll be an easy fix. And then I don't know if anybody from WellCare is here, and we had talked about this a little in the MCO meeting that the association has. I know I'm having this issue, and somebody else said they were as well, that when we send in our Medicaid claim, it wants the Medicare HIPS code on the claim, and it denies it on the front end. So we never get a claim number or anything to appeal.
Hey, Ann Lynn, good morning
Yep.
to you. This is Stuart on with WellCare, and I know Erin Allen is on, Provider Relations Representative. I know she's been working on that. I believe Erin is on. Erin, are you on?
I am.
Thank you. If you, yeah, give an update. Appreciate it.
Yes, we are aware of claims being rejected for needing a HIPS code. I do have some examples from several different home health groups. I have Anlin's examples as well. And I have sent all of these examples to our operations team where they have been reviewing these to try to determine what is going on, why they are firing that rejection. And we actually have an internal meeting later this week, so I'm hoping to get an update for that then. And we are working on this to try to get a resolution.
Here's just an idea, and I came up with this yesterday.
Okay.
I was looking at one of mine, and I noticed that that patient had changed their Medicare to WellCare Medicare. So they have WellCare Medicare and WellCare Medicaid. So I'm wondering if it cannot distinguish the system between their Medicare claims and their Medicaid claims. That could be totally wrong, but that was just an idea I had when I noticed that they had changed to WellCare Medicare.
Well, I'll definitely take that down and bring that up in our meeting on Thursday.
I have a question. Will you all be doing a work project to work on all the denials related to this, or will each individual location have to work independently and rebuild?
I will have to get back to you on that. I can't speak for sure, but I think that they would have to be resubmitted since they're not in our system. I do think some has made it into our system. I know the examples Annalyn had gave me, they was rejected even though she had sent them online. So I'm not 100% sure on that. And I will also make a note to ask that as well.
All right, that's all I had on that one.
And Evan, I'm sorry, I've got an issue. I'm going to have to sign off.
No worries. Thanks, Susan.
Thanks. All righty, that's all of the new business. Evan, if you want to just do the general discussion.
Sure. Just looking for any updates from the MCOs here, billing, PA, or other general home health issues.
Evan, this is Stuart again. Other than what we were just talking about, we're not aware of anything, and our auth approval rates remain high. I think around 95% or so threshold. So other than what Erin was just updating about, we're not aware of anything else.
Thanks, Stuart.
This is Herb with Humana. Other than what I had mentioned, using the therapy data tied to third-party vendors. But it's rare and to happen a lot. But other than that, we haven't seen any trends or anything, and we're still at a high. I think we're around 93% of an approval rating.
Thanks, Herb. We'll jump to UHC. Suzanne, if you're still on.
Yes, sorry, trying to get off the mute button. Hi, I'm not aware of anything. If you guys have anything and want to send it to me, that's fine, but I don't have any issues or anything.
Thanks.
Real quick, Susan.
Are you asking me?
Yeah. Yeah.
Oh, okay. Yes.
I have sent you a couple emails, and then
Yeah.
I never got a response, and I contacted, can't think of his name, and he asked me to go through just the 800 number. I've done all that. I'm not
Okay.
great hopes. My issue is I was told that since we're not in, and I'm trying to accommodate every patient that has UHC because nobody will take it, whether it's Medicare, Medicaid, commercial. So I'm doing a lot of individual contracts. But I was told on Medicaid that if I went through the online and I did the authorization, and at the bottom it does say that, I'm agreeing to take the state rate. for the Medicaid services, which is fine. That's what we'll do it for. But I am not being reimbursed the state rate. So I'm been trying to find out, is that because I'm out of network? Is there some other issue? And when I called the vendor number, they didn't even know what state rate was. They were like, well, what's a state rate?
Oh, no. Okay. Well,
he was just sending it back through, and I think one's already come back, and it did not. I think I'm being shorted like $3 every visit.
okay. Would you send me the last email so that it's at the top of my inbox, and I will work on that for you today?
Thank you.
You're welcome.
Is there anyone else from the MCO side to do a quick update?
Yeah, this is Jeb Teichman, CMO of Passport by Molina. We don't have anything new.
Thanks, Jeb. I think that just leaves Etna. All right, maybe we don't have anybody on from there, but we'll go to any other updates from DMS and or Commissioner Lee.
Evan, I believe Jonathan Scott is on with a DMS update. But before he hops on, I do want to let you know that tomorrow is Kelly Sheets' last day with the Department of Medicaid. So you'll have to send everything directly to me. So happy for her, sad for us. But I just wanted to let you know in case you you need something, you can just send that directly to me.
Thanks, Aaron. Appreciate it. And thanks, Kelly.
And good morning to the Home Health TAC. My name is Jonathan Scott. I'm the Chief Legislative and Regulatory Officer with DMS. We are here today to talk to you. I think you all are the first ones getting the presentation about the restructuring that we're doing of our Medicaid Advisory Committee framework. So we're just going to run you through the new Medicaid Advisory Committee and the newly federally required Beneficiary Advisory Committee. So we have a brief presentation here for you to talk to you a little bit about it. In July of 2025, so just a couple of months away, 42 CFR 431.12 is going to become effective. And that is going to completely, it is going to have some changes to our Medicaid Advisory Committee. As you all know, the MAC, it's the Advisory Council on Medical Assistance. It's located in state law, but that was implemented in order to follow a federal requirement. And the federal requirement has changed as part of these new federal rules. So we're having to make some changes. We're using the structure of the MAC, and then we're adding on some new individuals. The most significant part of that is that 25% of the Medicaid Advisory Committee is now going to be made up of Beneficiary Advisory Council members. And there's going to also be a revolving member representing the MCOs. So those are pieces, and this is some. You all will have access to this slide deck after this presentation. Just so this is some notes you may want to go back and review. We've been taking in some data. We've held a couple of virtual forums and conducted a survey that was going on over the last. Towards the end of 2024, and then so I think that's it. Aaron, you can jump to the next slide if you would. All right, so this is the new Beneficiary Advisory Council that will be starting up. If you know anyone that would be interested in applying, who is a current or former Medicaid member, or a parent, guardian, or caregiver of a Medicaid beneficiary, We are taking applications now through May 29th. We're going to have this group in place by July the 9th, and we are looking forward to them being able to start meeting and to start giving us policy advice in September. It's going to start out with a staggered terms, and then eventually it's going to be 4-year terms. And then we're going to need lots of people because we're no longer allowed to reappoint folks after their first. You can't serve consecutive terms, so you can serve 4 years, off for 4 years, and then back on for another term after that. All right, and then Aaron, if you could hop to our next slide. And then this is how we're going to be restructuring the MAC. As you can see, there's 5 existing ex officio members. There's 14 members who are appointed via statute. We also have 5 consumer advocates who are appointed. And then there's going to be the 7 new members from the Beneficiary Advisory Council that we were just talking about. And then there's going to be 1 nominating organization appointment from the MCOs. It's going to be a rotating thing, so each MCO will have 1 person, hopefully over the course of 4 or 5 years. Again, staggered terms going forward. We have a situation where some folks are going to have terms that expire after the start date of the new MAC, so they will be appointed automatically to serve on the MAC. We have some other situations where folks' terms have expired. If you are a member who is serving in an expired term, we won't be able to automatically reappoint you. So we will be working with your nominating organization and trying to figure out how folks will continue to serve on the committee. Then finally, the applications for the new MAC open until May 29th. So about a month from now. You can check out this website here. We plan to have quarterly meetings, and the first one again is going to be in September 2025. We're looking to have everybody in place by July the 9th. And then our next one, that's all I had for you. Do we have any questions or comments about the new structure? And then if you have other questions, please feel free to email myself, email Aaron. There's also a MAC TAC inquiry things at kymactac@ky.gov if you want to send an email as well.
Actually, I did have a question, so I was trying to get unmuted.
You're good.
So other than the makeup of the committees, is like the purpose of the committees or anything changing?
No, the scope is going to stay the same. Their 431.12 has some additional things, kind of starting points for why we might be getting advice, areas to advise about. So I would say that the scope may expand a little bit, but so we'll also be looking at that as part of our scope. But the existing statute also has a pretty broad scope as well.
Thank you.
Okay.
All right.
And I did want to mention, if you know of anybody who's interested in serving, you're welcome to also give them my email address and I can send them the application as well.
Will do. Thanks, Aaron. Thanks, Jonathan.
Thanks.
Thank you.
All right. I think that gets our general discussion items taken care of. We don't have any recommendations here today, so possibly some next time related to our topics here today. And Susan will still be our MAC representative, and our next TAC meeting is June 10th, 2025. So
Did did you want to discuss, do we want to change that since, or do you want to just carry on? I'll
Oh,
be
yeah.
on vacation.
Yeah, and Anlin can't make the next TAC meeting, so Aaron, can we work on a couple dates to shoot
Absolutely.
that, if that's okay? Awesome. So we
Do we
will.
prefer to stay on a Tuesday if possible?
Let me look, I should be any other June Tuesday. Yes, if we want to keep it in June, I can do the 17th or the 24th. If
24th.
Everybody else. 24th.
I'll look at those dates to make sure there's no other tax, and if those are covered, I'll send you guys some alternate dates and times.
Thank you.
Sounds good. Thanks, Aaron. We appreciate it.
No problem.
With that, I think we can, do we need to take a motion to adjourn?
I'll make that motion.
I'll second.
All those in favor?
Aye.
Aye.
Any opposed? Yeah, we are adjourned.
Thanks, everyone.
Thanks, everyone. Appreciate it.
Everybody have a great day.
You too.
Thanks, Aaron.